topic, and I think we have a workshop to go over some cases, and then I'll be coming back to talk about ablation of atrial flutter. These are my disclosures, which I don't have any ownership or stock in any of these companies. So just to kind of take a step back, and I think Jeff Winterfield made a great point at his beginning of his talk. This is not a board review course. You're not expected to know everything at the end of this course, but it's a way to introduce you to all these important concepts. You'll see that wherever you do your EP fellowship, everybody does things a little differently, different catheters, different setups, different mapping systems, but the principles are all the same. And once you figure that out, you can work with one attending and work with another attending, and even if the displays are different, you'll figure out that the principles that each person is following are pretty much the same. So what are the causes of supraventricular tachycardia? You know, as a general cardiology fellow, you kind of learn what an SVT is. That includes sinus tachycardia, AV nodal reentry, AV reentry using an accessory pathway, atrial tachycardia. And when you hear the term PSVT, in general, that refers to these three tachycardias. These in the past, and if you look in old literature, were all called PAT, or paroxysmal atrial tachycardias, because they didn't recognize that these were really the mechanisms of most of these PSVTs. Junctional ectopic tachycardia sometimes is in that category. It tends to occur in the postoperative state, particularly in pediatric or congenital heart disease patients, or with isoproterenol when you infuse it in the EP lab. Atrial flutter and atrial fibrillation are also SVTs, but we can usually distinguish those or diagnose those on an electrocardiogram and really don't put them in the category of the terminology of PSVT, as is MAT or multifocal atrial tachycardia. So these are the three main mechanisms of SVT. Those percentages are based on a study that we did nearly 20 years ago on the percentages of these categories when patients came to the EP lab with a diagnosis of PSVT. And so 2/3 of the cases of PSVT that came to the EP lab were AV nodal reentry, about 1/3 were AV reentry, and 5% were atrial tachycardia. Nowadays, I would say that those numbers are different. There are fewer patients with pre-excitation or WPW that come to the EP lab, and there are a whole lot of patients who come to the lab with atrial arrhythmias as a consequence of surgery, maze procedures, and particularly catheter ablation. The first step before we talk about what happens in the EP lab is to look at the electrocardiograms. And I'm realizing this is increasingly a challenge. You know, we have Epic as our EMR. You can go through Care Everywhere and you can read all the reports and everything, but one thing you can't look at are the EKGs, of course. So the only thing that you really care about is like going to see an orthopedic surgeon with all your records, but not the x-ray. So make sure you get the primary data, and you will start to realize how important that is when you get patients referred to you with AFib that don't have AFib once you find the tracing, or VF that's artifact. So look at the tracings. Let's look at this tracing. This is a patient with recurrent PSVT. You can see a tachycardia that terminates, sinus rhythm with a different PR interval. Move my mouse here. And then resumption of tachycardia here. So is this an atrial tachycardia? And do we have an audience response for this? We may not. I just have them for the workshops. That's okay. It's the only question I really have in this talk. Is this an atrial tachycardia? Is this a junctional ectopic tachycardia? Or is this AV nodal reentry? So again, move this mouse. Here is a tachycardia. There's a P wave following each QRS. There's no P wave here. There's sinus rhythm with a shorter PR interval. A junctional beat, and tachycardia. So is this an atrial tachycardia? Who wants to say that? Is this a junctional tachycardia? Raise your hand if you think it's a junctional tachycardia. Raise your hands higher than your head. And is this AV nodal reentry? Oh, good. All right. So it's not an atrial tachycardia because the atrial rhythm is not what's driving this. It doesn't start with a premature atrial beat or an atrial tachycardia. It's tempting to think it's a junctional tachycardia because it starts that way, unlike in the EP lab when we introduce premature atrial beats to engage the slow pathway and induce AV nodal reentry. This is initiated with a premature junctional beat, but it terminates reproducibly with VA block. And so these are important concepts. Look at how they start, look at how they terminate, look at transition zones. These are where you're going to find the answers to the diagnosis of the rhythm. So this is AV nodal reentry initiated atypically with a premature junctional beat, and this has been suggested to be more common when patients are treated with digoxin for AV nodal reentry or SVT because it slows the sinus rate and increases junctional automaticity. So these are the three categories that I'm gonna put the talk into, and I think it's important when you walk into the EP lab to also think this way. The first thing you're gonna do, whether it's looking at intracardiac recordings or pacing, these are considered baseline findings. You know, what are the clues when you walk in the lab that this person's going to have one of those three tachycardias? The second thing after you induce tachycardia, which is really required in most of these cases to make a diagnosis, are what are the characteristics of that tachycardia? And then the third part is what kind of pacing maneuvers do you do during tachycardia? So when you walk in the EP lab and you put catheters up and you record electrograms and you do some pacing during sinus rhythm, what are the clues that patients are going to have one of those different types of tachycardia? Well, one is if they have dual AV nodal physiology, right? If they have evidence of a slow pathway, as soon as you see that, you're pretty suspicious this person's going to have AV nodal reentry. But it's not diagnostic, right? They might also have an accessory pathway. So what are the clues that they have an accessory pathway? Pre-excitation is an obvious one, but a lot of these patients, their pathways are concealed. They only conduct retrograde. And so what are the clues that they have retrograde conduction up an accessory pathway at baseline? Now think about what would you be looking for? You would look for abnormal activation retrograde with ventricular pacing, whether there's eccentric atrial activation, whether there's extranodal response to Hisian pacing, and we'll kind of go through all these things. And so what are these baseline findings and how common are they? Again, this is data from a paper in JACC, which I think is referenced later, that we looked at 200 patients with PSVT in the EP lab and how common these observations were and how predictive they were for each of the three diagnoses of AV nodal reentry, orthodromic AV reentry using an accessory pathway, or atrial tachycardia. So if you have pre-excitation, which only occurred in 15% of patients in this study, the likelihood you have ORT is 86%. It's not 100%. Those patients can also have AV nodal reentry. They also can have the accessory pathway as a bystander, which is unrelated to their tachycardia. So they might have more than one tachycardia, or it's a bystander. If the VA block cycle length is greater than 600 milliseconds, it's just another way of saying that there's really no VA conduction when you start pacing. If there's no VA conduction, it's very unlikely that there's an accessory pathway. Now, you might have an isoproterenol dependent or a pathway that's not evident at the beginning when the patient's deeply sedated, but that's quite unusual. The likelihood they have ORT is very rare. But you can have AV nodal reentry. Remember, AV nodal reentry involves the perinodal structures, and a lot of times at baseline there is no VA conduction. So that does not rule out the likelihood of them having inducible AV nodal reentry. Dual AV nodal physiology, again, it's present in over half of patients who come to the lab with PSVT, but it's not diagnostic, but it's pretty suggestive. And when you put catheters up and you see clear evidence of a slow pathway, it makes you start thinking this person's going to have AV nodal reentry. Decremental VA conduction is another way of, sorry, this mouse is just jumping all over. It is another way of saying that it's unlikely to have a conventional accessory pathway, which does not usually conduct in a decremental fashion. Parahisian pacing is a maneuver. Again, we put it in this category, even though it's pacing. It's not a maneuver done during tachycardia. This is a maneuver done during sinus rhythm. I think that leads to a lot of confusion. This is not a pacing maneuver that's in training or anything. This is done at baseline to look for evidence of a perinodal or septal accessory pathway. It takes advantage of the fact that the His-Purkinje system is insulated, as does the other pacing maneuvers of differential RV pacing, pacing from the base versus the apex. And today we don't have time to go through all these, but I'm going to kind of highlight some examples of the ones that I think are the most important. In general, pacing maneuvers are more specific than pharmacological maneuvers. You'll see a lot of people want to give adenosine in the EP lab to determine if there's a pathway, et cetera. It can be useful if you're really struggling to make a determination of whether there's a pathway, but in general, it's not specific enough to hang your hat on. So what does pre-excitation mean? It means that the ventricles are excited prior to when you would expect them with conduction over the His-Purkinje system. And it's very important to know what that measurement means. It means the measurement from the earliest His recording. You can see here on the surface EKG, you have atrial pacing with one-to-one conduction and a sudden change in the QRS morphology. And the HV interval, which is the measurement from the earliest His recording to any ventricular signal, typically the earliest QRS on the surface. Excuse me, and you can see that the HV interval here is negative, it's -10. The His recording is after the onset of the QRS. When there's atrial pacing that results in block in the pathway, you have an abrupt change in the QRS morphology, and the HV interval suddenly becomes normal at 35 milliseconds. Less than 35 milliseconds is in general considered pre-excited. That's abnormally short. So this sounds simple, but you have to make sure you understand the principles here. The local appearance here doesn't change. You're not measuring the HV from the H to this V. It's to the earliest V anywhere, which is typically where the pathway inserts. How do you define a slow pathway? The definition of dual AV nodal physiology is shown in this slide. This is from Mark Josephson's textbook. Pablo Dennis, who was at Northwestern, actually was the first to describe this in humans. Just retired. He was a tremendous colleague, and we'll miss working with Pablo. But in this nice diagram, what you need to remember is the A1, A2 versus A2, H2 curve. That means that when you introduce a premature atrial stimulus, which is the A1, A2 coupling interval, so you're basically giving a PAC. You have a drivetrain, which is referred to as A1 or S1, in the atrium A1, and the ventricle V1. The second, the number 2 is the premature extra stimulus. And you measure the AH interval, and it's going to get longer. It's going to decrement. But if there are 2 discrete physiological pathways, you'll get block in one, and it'll jump to the other one. And so this definition of a greater than 50 milliseconds jump in the A2H2 interval is how we define it. It was based on a decrement of 10 milliseconds. We usually come in by 20 milliseconds, which we've shown to be just as sensitive to a jump. Patients can have more than one jump. Patients can have no jump. They can have AV nodal reentry and have a subtle difference between the fast and slow pathway. All it means is that they have, the properties of the fast and slow pathway are different enough from each other that it can set up reentry. But most people will have a jump like this. And here's an example of that. Here's 600, 420 is a coupling interval, longer than usual, but you can see that the AH is 150. You bring in the coupling interval of that premature beat by 10 milliseconds, and the AH jumps out to 330. And what else do you see here? You can label this. This is an echo beat. So remember, blocking in the fast pathway and conducting over the slow pathway is a necessary but not sufficient thing for initiation of AV nodal reentry. In this case, it caused block in the fast pathway, integrate conduction over the slow pathway, and then that allowed the fast pathway enough time to recover and go back up. So you have a single echo beat. Bringing that premature beat in any sooner is not going to help you induce tachycardia. This is now blocking integrating the slow pathway, and usually it means you have to give some isoproterenol or wake up the slow pathway.
Can you, before you go to the next slide, can you clarify for everybody, because I'm not sure everyone can tell, how you know that there is an atrial event superimposed on top of a ventricular event, because everything's happening at the same time.
Yeah.
So that's obviously what the echo is. It's going back to the atrium. How do you know that?
Yeah, so when we talk about atrial and ventricular depolarizations, it's really important to look at the electrograms on each catheter at baseline, so you really know what's being shown, so that when you see tachycardia, you can differentiate these. That's one point. The second point is I try to be a minimalist in the EP lab, and we only have 3 catheters up at the beginning. And we didn't talk much about that, but I start with a high-rate atrial catheter, an RV catheter, and a His catheter. And we use a mapping system still for these cases, but I don't put in a coronary sinus catheter at the beginning routinely, because then that requires 4 catheters, typically requires accessing 2 veins. So I try to keep it simple. If I were to move one of these, I would move one of those into the coronary sinus, which we often do later if you're still need to make a diagnosis. But the point is that you need a catheter that clearly shows an A and a V. And so if you look at this, again, we don't have sinus here. You want to look at sinus. But you can see with atrial pacing that there's an A, there's an A, a His, and a V. And if there's an A in here, you're not going to be able to see it. But the high-rate atrial catheter shows a pacing stimulus, atrial capture, and then you can see this has to be an A. There's no ventricular signal coming from here. So that's a great point. And in particular, in the coronary sinus, you'll see an A and a V. And you have to be very careful. A perfect example is when you're monitoring VA conduction with junctional ectopy when you ablate a slow pathway. And you'll hear about that, but when you look for junctional ectopy, that's what is necessary to make sure you're ablating the slow pathway. You can't monitor AV conduction, so you, by default, monitor VA conduction. So you have to have a great atrial electrogram. If you have an A and a V and you get a junctional rhythm, you may not be able to determine that. So it applies to many different scenarios. That's a great question. This is, I think, from the Heart Rhythm Board Review course many years ago, so I stole this slide from Hugh Calkins to talk about Hisian pacing. So what is the evidence of an accessory pathway? In general, as Jeff showed, some of the most challenging cases are differentiating AV nodal reentry from a septal pathway. However, this only will help you identify septal pathways that conduct more rapidly than the AV node. So the case that was shown earlier, Hisian pacing probably wouldn't be very useful. The principle is that the His-Purkinje system is insulated, and that if there is no accessory pathway and you pace on the His, I think people, now that we're doing a lot more His bundle pacing, appreciate this physiology a little bit better. You're going to conduct quickly to the, across the AV node to the atrium. But if you lose capture of the His and capture only the right ventricle, you have to go all the way down to the RV apex to engage the His-Purkinje system and come back up. So it takes a lot longer. So in the red, you're typically not just capturing the His. This is non-selective His capture would be the term we would use now. But you're capturing usually the right ventricle plus the His, or the right ventricle plus the right bundle. And then when you lose His capture and get RV capture only, you'll be able to see this response. Unlike if you have an accessory pathway on the septum close to your pacing site that conducts faster than the AV node, you'll see that with His capture, you go over the A, over the AV node, or the pathway straight into the atrium. But if you lose His capture, you still go over the accessory pathway to the atrium. So that number will be the same. So here's an example of an extranodal response during Hisian pacing. And again, we don't have time to go into all this, but how do you determine if you have His capture? We talk about this a lot more now with permanent pacing, but you can look at the intracardiacs, or you can actually look at the surface and usually determine with a wide QRS you don't have His capture, and when the QRS narrows you do have His capture. Those are the 2 patterns you're looking for. You tend to start at a very high output, lower the pacing output, and you'll tend to go from His capture to loss of His capture. And at any lead, you can measure the stim to A. If it's the same, then it is considered an extranodal response, which implies that there's an accessory pathway. And here's an example of His capture. And in this case, there's a segment between the stimulus and the QRS. This may be pure His capture, and RV capture only. And the stim to A jumps out, consistent with a nodal response. So this is a maneuver that will come in handy in certain situations in the EP lab. But like all these maneuvers, the more you practice, the better off you'll be. So I would encourage you, even with AV nodal reentry, you got a catheter at the His, just start pacing at high outputs and look at these responses. So try to go through all these maneuvers in every case just so you'll be comfortable performing them. This is a pitfall of that maneuver. You can see narrow QRSs here and wide QRSs here. And you can see 3 different stem to A times. Here's 1, here's 2, and then this red one is the same whether you have His capture or not. And this is when you pace too close to the atrial, you capture the atrium by pacing too proximally at the His. So you want to pace distal where you have a very small or no atrial signal so you don't get atrial capture. If you get atrial capture, your stem to A interval is going to be very short and it's not going to change regardless of whether you're capturing the His or not. This is another, I think, important concept. It's, I think, emphasized on the boards a lot too, is just retrograde conduction. We talk a lot about Ashman's phenomenon and antegrade right bundle, but there's a lot of retrograde right bundle branch block that occurs in the EP lab that if you recognize it will be very helpful in making a diagnosis. And so the principle here is that if you have normal AV node conduction without an accessory pathway and you pace the ventricle, you will get a pacing stimulus here with a His and then an A. So you get retrograde conduction up to the His and to the A. And if you get a retrograde right bundle branch block, it won't go directly up to the His. It'll take longer, so the His will be pushed out, and so will the A. So the A is coming after the His. The atrial activation is dependent upon His-Purkinje conduction retrograde. That's different than if you have an accessory pathway and either a pacing beat or a premature ventricular extra stimulus, which is how we typically do this. You'll see that when the His gets pushed out here, the VA doesn't change. So VA conduction is independent of conduction over the His bundle. That's proof that there's an accessory pathway. This is a great maneuver, and again, I would encourage you don't always get retrograde right bundle branch block with premature ventricular beats, but the more you do this, the more you'll see it, and it also emphasizes the importance of having a pretty good His recording at the beginning of your EP study. All right, since you didn't see that slide. So the next step is you've induced tachycardia, and you want to know what type of tachycardia it is. So we're going to go through a list of tachycardia characteristics, but before I show you, I want you to just think about this. So what are the things that when you induce tachycardia you can look at? One is how fast it is, right? What's the tachycardia cycle length? We talk about the RP interval with catheters up. It's the VA interval, particularly the septal VA interval. And if you can't see it, you can look at other VA intervals. What other things happen during tachycardia that are useful diagnostically? Yeah, so I think someone said wobble also. So if there's variations in the cycle length of the tachycardia, which tends to occur at the beginning and at the end, it's not always present, but if it's there, look and try to deduce is the atrial changes happening first, the changes in the AA interval preceding the changes in the His intervals. If they are, that tells you the A's are driving the tachycardia and that it's an atrial tachycardia. The opposite is true if it's an AV nodal dependent rhythm where the His changes are changing before the AA. It's another way of saying that the His and the A are linked or not. Because if you think about that, that's really the same concept, or the His and the A linked. The problem with wobble is sometimes you get compensatory changes in the other part of the circuit and you'll see changes in both measurements. But it is a useful thing to look for. What else? Just imagine you're looking at an EKG like we did at the beginning. What happens during the tachycardia that might be useful? Bundle branch block. So if you get a bundle branch block, that alone can be useful. If you get a bundle branch block, it can also affect the intracardiac timing. And so if you have a bundle branch block and it changes the VA interval, that can be diagnostic, right? What other things can happen? Cessation, so termination. How does it terminate? We showed that first example without any intracardiac electrograms, it terminated with VA block. These are useful things to look at to make a diagnosis. What else? The onset, is the onset dependent upon blocking an accessory pathway? I showed you loss of pre-excitation when we were pacing the atrium. If that loss of pre-excitation initiates tachycardia, it's pretty likely that that block was required to induce and that the pathway's part of the circuit. So these are all the things that can happen. Another one that is very useful is when you have a one-to-one tachycardia and you suddenly lose VA relationship. So you get 2-to-1 AV block, for example. You know that if the tachycardia is continuing and you have 2-to-1 antegrade block, the ventricles are not part of the circuit, and that rules out AV reentry. So if you watch long enough and see things happen, you'll often be able to make a diagnosis without having to do any pacing maneuvers. In fact, with AV nodal reentry, that's probably more common than not. So here are the things we talked about. If the septal VA interval is very short, which occurs in about half of the time, it virtually rules out AV nodal reentry. And that cutoff number is in dispute a little bit. In adults, it's about 70 milliseconds. In children, it may be as short as 60 milliseconds. But if you have simultaneous activation of the A and the V, then it can't be an accessory pathway. It can't go over the His-Purkinje system, activate the ventricles, and then go up retrograde up the accessory pathway.
Just to clarify, you accidentally misspoke and you said it rules out AV and RT. You meant it rules out AVRT.
AVRT.
So,
Yeah. Yes. Can we redo that?
no, you got it.
Yes. If the septal VA interval is less than 70 milliseconds and the atrium and ventricle are activated simultaneously or in parallel rather than in series, that rules out AV reentry with an accessory pathway. It doesn't rule out an atrial tachycardia that coincidentally is conducting with a PR interval that's equal to the tachycardia cycle length. So that's why I say it's not 100%, and I can show you examples of, at least for a few minutes, it'll look just like AV nodal reentry, and you'll discover it's not. It's an atrial tach. Eccentric atrial activation. So if the tachycardia results in earliest activation in the left free wall, that's not AV nodal reentry. If it is, it's almost reportable because it would have to involve some AV nodal structure that's away from the compact AV node. So these things can happen, but that would be super unlikely, and virtually, if it's far enough away, rules out AV nodal reentry. If you have termination with AV block, it's reproducible. You have one-to-one AV conduction. It terminates with AV block. Then that has to be an AV nodal dependent rhythm. It can't be an atrial tachycardia. When atrial tachycardia stops, unless it's due to a premature beat or some other change, it's not going to block in the AV node at the same time it stops. It's just going to continue and conduct. If the VA time increases with a bundle branch block, that's one of the beautiful board questions. Anything that's got 100% up there, like there's no controversy. And so we'll show a diagram of that, but if you have a left bundle branch block and the VA time increases by more than 20 milliseconds, that's diagnostic of AV reentry using a left-sided free wall pathway, ipsilateral block, causing an increase in the VA time. The mere development of a left bundle branch block is way more common in AV reentry. The initiation of AV nodal reentry requires blocking the fast, conduction over the slow, so that onset does not stress the His-Purkinje system like it does when you initiate AV reentry. So you tend to not get that bundle branch aberration. There's other reasons too, because AV reentry tends to be faster and you're more likely to get bundle branch block. Is the induction dependent on a critical AH, meaning you've blocked in the fast pathway and gone over the slow? It's probably AV nodal reentry, but there are some accessory pathways that require that long PR interval to initiate tachycardia. Is it really slow? You'll see older patients, particularly older patients that come to the hospital on AV nodal blocking drugs, that will have tachycardia cycle lengths of 500 milliseconds. They'll have a SVT of 110 beats a minute. That's usually AV nodal reentry. Something has to be conducting really slowly, and it's pretty unusual. It goes over the AV node and up a rapidly conducting pathway and gives you a tachycardia cycle length that long. If you have AV block during tachycardia and it continues, that means the ventricle is not part of the circuit. It rules out ORT or AV reentry. And then we talked a little bit about the relationships with wobble, which was not something that we looked at in this study. Here is an example. This is a pediatric case. So I show it I tell you that because there's 4 catheters in here. You can see a His catheter, a mapping catheter, CS, and RV. This is a patient with a regular narrow complex tachycardia. And just was brought up, where's the A and the V? Well, if you look here on the CS catheter, that's all A. So during tachycardia, you know this is an A, not a V, right? Sorry, right here. So you have simultaneous atrial and ventricular activation, and you have spontaneous termination with AV block. In fact, it slows a little bit before it blocks. What's the diagnosis? It's AV nodal reentry. The VA interval is too short to be AV reentry, and it terminates with AV block without a premature beat. It can't be an atrial tachycardia. So a lot of these diagnoses are made by the process of elimination. You're excluding other diagnoses as you go.
A question just came up on the previous slide to clarify how you know what's A and V. And
on this slide?
yeah, sorry, I know you said
yeah,
it, but just
I think
to
if you
slowly
look
go
at
over
the
that.
sinus beat, you can determine that this is all A and that that's a small far field V.
Yeah, got it. I mean, the key is to look for so we don't have an HRA catheter in here that only has A.
Right.
So you can, when A and V are separate, like they are in this sinus beat, look at all the catheters we have. Is there any catheter electrode pair that has only A and not much V? And the answer is CS910 is really the only one. On CS78, you have A and V, A and V, A and V. So if they're on top of each other, it's really hard to tell. But in this one, CS910, there's only an A and a very small far field V, so you can infer that if you were to go back here and you see the signal, that must be an atrial signal because this catheter is only recording atrial signals, not V. Everything else, it's hard to say.
Yeah, this would be the only other channel maybe you could say this A
Yeah.
looks like that sharp A, and you
Yeah.
can kind of, but that's
Thanks, that's very
important.
helpful, I think, because they're still learning how to
Yeah.
process all of this stuff. That was helpful. Thank you.
So this is diagnostic. You could just go ahead and ablate, but you don't want to. You want to make sure you reproducibly can induce a tachycardia, that you fully understand what the baseline is before you go turning on the RF and delivering RF, because if you don't have a good endpoint, then you're not going to know when you're done. So the toughest cases are cases you've induced a tachycardia once. You cannot, for AV nodal reentry, the fast and slow pathways are so similar, you have difficulty inducing tachycardia, and you induce it once, you do a slow pathway ablation, you get junctional ectopy, your endpoints are difficult. So unless you completely eliminate the slow pathway, it's hard to know if you're done. We talked about the effect of a bundle branch block. This is a classic figure from Dr. Josephson's book here. Here's an example of AV reentry using a left-sided concealed accessory pathway. The surface would show this P wave after the QRS. And this is the shortest path, but when you get a left bundle branch block, it has to activate the ventricle over the right bundle, slowly conduct through the myocardium, unlike the His-Purkinje system that takes time. It's also a longer circuit, and it gets up to this accessory pathway here, making the VA time long. Now, this is an extrapolation of what you learn on surface electrocardiography, is that the tachycardia cycle length gets longer. And that is common, and you can see it happens here, right? But what can happen is that the conduction time here gets longer, and that allows this to recover, and this gets shorter. So you get a compensatory shortening in the AH interval. The tachycardia cycle length may not change. So remember, in the EP lab, you're not looking at the tachycardia cycle length, you're looking at the VA interval. And you're looking at the VA interval from the beginning of the ventricular activation to the A. Because this VA interval here isn't going to change. The local VA interval is not what's going to change. So let me show you an example. So this is the same patient that had AV nodal reentry, now has this inducible tachycardia, the same catheter setup, surface EKG, His, mapping catheter, CS, RV, and there is a left bundle branch block pattern with a normal HV interval, so it's not VT, and it narrows, and you can see that the VA interval from the onset of the surface QRS to this A gets shorter when the left bundle branch block resolves. So that's diagnostic of a left free wall pathway causing AV reentry. All right, so that's step one. Step two is to realize all the other things that can throw you off. One, the tachycardia cycle length doesn't change. And it doesn't change because when there's a left bundle and it takes a while to get to the pathway, the AH is short. It's hard to see, but that's the A, that's the His. And then when the left bundle resolves, the AH gets longer. Here's the A and the His. And the tachycardia cycle length, at least at the beginning, is the same. I'm sorry, this mouse is difficult. So, am I the only one with control of this? I feel like someone else is moving it.
Yeah. Are you running that on a piece of paper, or is that on the fabric? So why don't we give you a piece of paper maybe and see if that helps?
Yeah, I don't want to point with this because then everybody can't see it.
Can someone just pass
Yeah,
it?
just throw me a piece.
See if this works. Yeah. While you're
This
doing
is real
that,
life. This is getting a mouse to work on a recording system.
Speaking of real life, a question came up is that you're saying, well, obviously that's the His, and people are like, huh? Yeah.
I don't think I said obviously.
How do I know if that's not the His, or that's not the His, or that's not the His? How are you deciding here which one is the His?
All right. Well, it's not a great example. I will give you that.
That was not. That wasn't my point.
And I didn't put the catheters in. This was a pediatric case. But
Yeah.
How do you know what's the His? I mean, it's some of it's ruling in and out. Here, I'm gonna have to. I just can't get that thing to work.
Yeah.
All right. So this is a signal, a signal, a signal, and a signal here. So you have to sort out what's the A, what's the His, and what's the V. And part of this is when you're moving the catheter in the EP lab, you can kind of sort that out. But you often have the luxury of looking at other electrograms on your catheter. But this, with a narrow QRS, is the expected time to record a His. It's a discrete electrogram. It's consistent with a His. But there is some noise in there. So I can tell you that I think that's what the A and the His and the V are. But I can tell you it's not a great example. But this is particularly a challenge with catheter instability during tachycardia.
Yeah, I think it's a great point that this is real life, just as you were saying before. The point is that because the HV interval is so predictable in most people, unless there's His-Purkinje disease, which is so unusual to see in an SVT case, if you go to the beginning of the QRS and you go backwards 40 to 60 milliseconds and you see a little blip that's predictably that far in front of the QRS, it's probably the His. So sometimes it is a question, but you say, all right, well, that's too close to the QRS, that's too far away from the QRS, so it's got to be that one. So it's one of the tricks that you use when signals are not optimal.
But it's key. And how do you know sometimes when you're ablating a slow pathway and you see a sharp spike at the end of the atrial electrogram, is it a His? You don't want to ablate the His. So sometimes you have to do pacing maneuvers to separate these electrograms to sort out what's A, what's His, and what's V. Just like diastolic potentials during VT, pacing will separate these. But before I finish that, you also, besides that there's no change in the tachycardia cycle, the local VA time doesn't change either, remember? It's from the onset of the QRS to the A. But the insertion site of the pathway, that doesn't care how long it took to get there. It's going to hit the V and then hit the A unchanged with a bundle branch block. All right, so what other things can you do when you're still not sure what the tachycardia diagnosis is? You can perform pacing maneuvers. The iconic pacing maneuver in the EP lab during SVT is introducing ventricular extra stimuli during tachycardia at varying coupling intervals. We refer to it as scanning diastole with premature ventricular beats. And the concept is trying to deliver a ventricular extra stimulus during tachycardia when the His bundle is refractory. Because if the His is refractory and you conduct up to the atrium during tachycardia, which is harder to do in sinus rhythm, but during tachycardia, then you know you've gotten up to the atrium over some other means, that the His bundle was refractory. You must have conducted up an accessory pathway. And so that's the classic teaching, and I think it's important for you to practice that in the EP lab, is giving PVCs with shorter and shorter coupling intervals during tachycardia that are synchronized to the pacing system. However, in the interest of time, I'm going to talk about just ventricular overdrive pacing, and Jeff showed the case of the value of that. I like this maneuver because sometimes you don't have a lot of time. The tachycardia will initiate, and it will often spontaneously terminate after 20, 30 seconds. If you can perform one maneuver, you have one opportunity, then you want to perform ventricular overdrive pacing. And it sounds simple, but you need to make sure that when you start pacing from the ventricle, that you're synced properly, and that the first pacing stimulus comes in at a long coupling interval so that you can gradually capture the tachycardia. You can't just blindly turn it on, or you may come in randomly and terminate the tachycardia with the first beat. So it's more than just understanding what rate and the response. You have to make sure you've entrained it and that you properly time the onset of pacing. And all the pacing systems are a little different, so you got to get familiar with how to sense properly, how to synchronize the first beat of your drivetrain, and how to make sure that which electrogram you're synced to on the recording system. But we tend to overdrive pace at about 20 milliseconds faster or shorter than the tachycardia cycle length, assuming that it's pretty stable and that there's not a lot of wobble. And if you pace and the tachycardia is AV nodal reentry, and you have activation of the atrium and ventricle in parallel, if you pace with a properly timed drivetrain, you'll initially get fusion, and then you'll finally start entraining it, and the atrial rate will accelerate, and you'll conduct up one limb of the tachycardia, and when you stop pacing, it'll come back down the other limb. And so you'll get this so-called VAV or VAHV response. All right, so that's what you would expect with AV nodal reentry. And here's an example of that. You're pacing during a tachycardia cycle length of 320, pacing at 300 milliseconds, and you conduct up here to the atrium. And how do you know which is the last beat that was entrained or accelerated? You look at the AA interval here. The pacing cycle length is 300. This coupling interval is 300. The next one's 360. This is actually probably the best measurement. Is there a pause after here? You have a VAHV. AV reentry is the same principle because you have a circuit that involves two connections between the atrium and the ventricle. And when you get conduction over the AV node and up the accessory pathway and start pacing, you get fusion. You eventually start to conduct up into the atrium. And then when you stop pacing, it comes back down the AV node. So you get a VAV response. And here's an example of that. Ventricular pacing during a narrow complex tachycardia with a pretty long VA interval. You get a V, an A His, and a V. This is in contrast to an atrial tachycardia. Even if you mimic an atrial tachycardia in a patient with dual AV nodal physiology with a pacemaker, as we did in this study, you will find that there's only one connection from the A to the V. You'll get block with fusion. You'll eventually, in some patients, not all, get conduction up into the atrium that overdrive suppresses this atrial tachycardia. And then when you stop pacing, the atrial tachycardia resumes and conducts. But this retrograde conduction results in block antegrade. So you get a VA, no V, VA-AV response. Sounds simple, but it can be difficult to interpret. And here's an example of an atrial tach. You can do this in the EP lab when the patient's on isoprel with sinus tachycardia. So next time you're in the lab and someone has AV nodal reentry and they're in sinus tachycardia and you pace the V and you don't induce AV nodal reentry, you'll see a VA-AV response. There's a little better His recording for you.
Yeah, the question that just came up is, so is the whole purpose of this maneuver just to rule out ATAC? Is that all it does?
No, but the response, as we just showed, VAV versus VAAV is. But we've ruled out atrial tachycardia, then we're stuck with AV nodal reentry or AV reentry. And so the other observations that we're going to show you, which Jeff showed very nicely, If you want to change where you do your fellowship, just give me a call. We need to look at those. I think that answers the question, right? So, but before we show that, we're going to talk about other pitfalls of just the VAV response, and I have to wrap this up too. We have pacing here. Now, if you just go left to right, you'll see VAAV. But if you look at the beginning, this is a long RP tachycardia where you have conduction over the AV node, antegrade in the fast pathway, retrograde in the slow pathway, giving you a long RP tachycardia. So if you start pacing the ventricle and you conduct to the atrium, it's only going to get longer. It's not going to get shorter. So you pace the V, you're not conducting to this A, you're conducting to this A. So it's really, when you refer to VAV or VAAV, you're referring to the conduction sequence, not just the pattern left to right. And so this is truly a VAV response. So that's important. And here's an example, just like the one that Jeff showed, where the second AA interval after ventricular pacing is truly the last one that was entrained. Other things can happen. You can dissociate the atrium from the ventricle completely, or the ventricle from the tachycardia. Sorry, you can just completely dissociate the ventricle from the tachycardia. That doesn't rule out AV nodal reentry. The AV node is what's the source of the reentry. The ventricles are not part of the circuit. If you start pacing and you terminate it, you might think, oh, I can't look at the VAV response, what a waste of time, let's reinitiate it. Go back and look at what happened, and often you'll see that you terminated it without ever getting to the atrium. If you terminate the tachycardia without ever getting to the atrium, then it can't be an atrial tachycardia, right? In fact, when you're struggling, sometimes pacing very quickly for just 2 or 3 beats and terminating the tachycardia and going back and showing you never got up into the atrium is a good maneuver too to rule out atrial tach. And here's an example of A. You burst pace the ventricle and it terminates it without ever affecting the A. These are pacing stimuli. And as we're going to talk about next to my last couple slides, you'll also notice that there was fusion when that happened. So not only did you terminate it without affecting the atrium, which rules out an atrial tachycardia, you never had full capture of the ventricles. If you have fusion, there must be antegrade conduction over the His bundle. How would you have gotten into the circuit if this is an AV nodal dependent rhythm? It can't be. So this is not just evidence that this is not just excluding atrial tach, it also excludes AV nodal reentry. So this right here is diagnostic of this tachycardia being AV reentry. How much time do I have? Like, I feel I'm already 5 minutes over. I'll go through this quickly since Jeff talked about it, but the post-pacing interval now, so we talked about ruling out atrial tachycardia. Now, how do we rule out AV nodal reentry versus AV reentry? If the ventricles are not part of the circuit, then the post-pacing interval is going to be long. So if the RV is part of the circuit, it will be short, and the number and the cutoff in the studies was the post-pacing interval minus tachycardia cycle length is less than 115. If it's longer than that, it's unlikely to be an accessory pathway mediated tachycardia. It's very likely to be AV nodal reentry, but it's not as diagnostic. There's subsequent papers have shown that if you have a decrementally conducting pathway, you can get a long post-pacing interval minus tachycardia cycle length, and the RV can still be part of the circuit. But if it's short, you ruled out, you've proven that the RV is part of the circuit. This is the original data from that study that Greg Michaud published, that the stim to A minus VA cutoff is 85. The post-pacing interval minus tachycardia cycle length cutoff is 115. Again, papers have shown it's not quite that clean, but if it's short, if it's less than 115, that's very useful. And then this is my last slide showing this transition zone that Jeff alluded to, which I think when you're dealing with a long RP tachycardia with concentric atrial activation, and you can't tell, is this atypical AV node reentry or is this a slowly conducting accessory pathway, the best maneuver is to look at what happens when you start pacing and you entrain it. And if you pace properly, as we talked about, and you get progressive fusion like this, then look and find out when the first atrial electrogram is that's pulled in. And in this case, the AA interval went from 280, suddenly 250. Well, was the His refractory here? Well, let's look up here and see if there's complete capture yet. Well, if you start here, the QRS is different. So this all must be progressive fusion. So these Fs depict fusion. I think you called it stable ventricular capture, but or morphology, but here's full capture with ventricular pacing. So there's fusion here. You've accelerated the atrial rate with fusion, and if you've ruled out an atrial tachycardia, then this has to be AV reentry. This is a great maneuver to do in every case you have. And I'll stop there. Thanks. Sorry I went over.
Can you just go back one slide? There were several questions about that concept of fusion. First of all, I wanted to clarify there are some scenarios in EP where we use the same term to mean two different things. One of those is the term linking, which means different things in different contexts, and progressive fusion also. So when you say progressive fusion now, that's very different from the Al Waldo entrainment criterion progressive fusion with different pacing rates.
Yeah.
But the point that was being made is if we asked you guys to figure out where the His recording is here, it's going to be a little challenging. And so as a cheat to figure out, is this paced beat happening when there's still a His bundle recording, meaning there's a wavefront coming downward, so I can't possibly be going back up past the His into the AV node. A cheat is looking at the QRS. So what does fusion mean? It means that that QRS was generated in two different ways at the same time. One was pacing. What's the other one? The other one is a wavefront coming down the His Purkinje system to activate the ventricular muscle. So if in this beat and in this beat it doesn't look purely paced, that means there must have been a wavefront that made it not only to the His, but all the way down, at least one of the Purkinje fibers, to the ventricle. So if that's true, then on this beat and this beat and this beat and this beat, wherever he's labeling fusion, meaning it doesn't look pure paced, the His bundle and the Purkinje system must have been refractory. Therefore, if anywhere in here you paced in the ventricle and you advanced the A, you got back up to the atrium, it was not through the His Purkinje system, because we know that was refractory because you came down it to generate part of the fused QRS. Does that make sense? So anyway, that just to clarify, because a few questions came up on that point. Sorry to belabor it.
What's this anonymous question asking system? It's so devious. Who are these people?
There's no accountability. I'm the bad guy.
There's no accountability. The next session are cases. Oh, you're talking about. I'm sorry.
Yes.
Okay, Brad, thanks very much.
Thank you.
Thank you.
Okay.